Hello my dear friends, today's lecture about seborrhea, acne, dermatosis rosacea, etiopathogenesis, clinical history, modern methods of treatment. Next, sebaceous glands. Sebaceous glands are exocrine glands that release sebum. These glands are connected with the hair follicles, and in most cases sebum is released through the same pore through which hair grows. Sebaceous glands are located on every surface of your skin, with the exception of your palms, bottom lip, and the soles of your feet. Next, sebaceous glands. Sebaceous glands are located practically throughout the skin surface except the palms and soles, and most are associated with hair follicles. Sebaceous gland composition. Triglycerides 41%. Wax ester 25%. Fatty acids 16%. Squalene 12%. Diglycerides 2%. Cholesterol ester 2%. Cholesterol 1 to 2%. Next, softens epidermis, giving it waterproofing properties, regulates water evaporation, blocks penetration of certain substances from the environment, imparts antifungal and antibacterial effect. Next, varying density of sebaceous glands distribution. Calp, face 400-900 centimeters to upper third of chest and back 300-500 centimeters to extremities 50 centimeters to. Next, in the average adult up to 20 grams sebum is secreted per day. Between 400 and 900 sebaceous glands per 1 square centimeter are located in seborrheic areas. Sebaceous glands are absent on the skin of the palms and soles. Very few of them can be found in the back of the hand and on the red border of the lips. Maximum activity of sebaceous glands in a healthy person begins at puberty and lasts up to 24 to 25 years. Next, sebaceous glands regulation. Androgens increase sebum production, and estrogen reduce it. The embryologic development of the human sebaceous gland is closely related to the differentiation of the hair follicle and the epidermis. The number of sebaceous glands remains approximately the same throughout life, whereas their size tends to increase with age. The activity of the sebaceous glands increases during puberty because of heightened levels of androgens. Androgens are well known for their effects on sebum excretion, whereas terminal sebaceous differentiation is assisted by peroxisome proliferator activated receptor ligands. Next, sebaceous glands regulation. The gland's skin sebaceous contain an enzyme called 5-A reductase, which converts less potent testosterone into more potent dihydrotestosterone, which is directly responsible for sebaceous gland activity. This stimulates the sebaceous glands, causing an increase in sebum production, which can lead to an oily skin. Are involved in skin problems such as acne. Next, seborrhea. Seborrhea is genetically determined disorder characterized by dysfunction of the sebaceous glands, quantitative and qualitative changes of skin sebum. Next, classification of seborrhea. Dry seborrhea, oily seborrhea. Mixed seborrhea. Next, treatment of seborrhea. If it affects the scalp, shampoos containing ketoconazole, zinc, and tar are prescribed. They are used at least 2 times a week to eliminate manifestations of seborrhea, but not less than 1 month. In milder forms of seborrhea, course with the location of lesions on the smooth skin, ointment, cream or solution of the antifungal drug are used 1 to 2 times a week for a month. In severe disease course characterized by the presence of foci with pronounced inflammation and dense layering of flakes, before use of antifungal drugs, exfoliating agents, salicylic acid, tar, and other drugs should be used, or soften the scales using oils and then use a shampoo with ketoconazole. At current therapy inefficiency, topical hormonal creams are added, and in severe cases, topical treatment is combined with the antifungal agents for ingestion for 1 week. Ketoconazole 200 mg/day, terbinafine 250 mg/day, and fluconazole 100 mg/day. Administration of isotretinoin to be ingested, as well as for the treatment of other severe seborrhea types, is possible. Treatment should be continued for 4 weeks. In the combined therapy, vitamins, anti-allergic drugs, sedatives, and drugs for the normalization of the gastrointestinal tract are included. Next, acne. Acne means eruption and vulgaris means common. Acne is one of the commonest skin disorders, if not the commonest. It has been estimated that 70% of the population have some clinically evident acne at some stage during adolescence. Acne vulgaris is a chronic disorder of the pilosebaceous apparatus caused by abnormal desquamation of follicular epithelium, leading to obstruction of the pilosebaceous canal, resulting in inflammation and subsequent formation of papules, pustules, nodules, comedones, and scarring with varying extent and severity. While the course of acne may be self-limiting, the sequelae can be lifelong with pitted or hypertrophic scar formation. Next, prevalence of acne. 60 to 80% of adolescents suffer from acne. Acne causes psycho-emotional stresses, suicide attempts, anxiety, depression, dysmorphophobia, and social maladjustment. Next, etiology of acne. Genetic factors. If both parents suffer from such disease, likelihood of its development in children is 50%. The number, size, and sensitivity of receptors of the sebaceous glands is genetically determined. Hormonal disorders. Absolute hyperandrogenism at androgenoproductivity of ovarian and adrenal glands, tumors, polycystic ovary syndrome, PCOS, adrenal hyperplasia. Relative hyperandrogenism, elevated activity of 5-alpha reductase, iatrogenic hyperandrogenism, anabolic steroids, androgens, progestogens, etc. Intake. The effects of stress. Pathology of the immune system. Gastrointestinal diseases. Next. Acne pathophysiology. Acne pathophysiology. Hyperandrogenism. Increased sebum secretion. Retentional hyperkeratosis. Reproduction of Propionibacterium acans, inflammatory and immunological reactions. Next. Photo. Sebaceous glands hyperproduction. Next. Photo. Occlusion of the follicular canal. Follicular hyperkeratosis. Saprophytic microflora activity of the skin. Next. Photo. Inflammation development. Next. 1. Androgens stimulate sebum production and proliferation of keratinocytes in hair follicles. 2. Sheets of desquamated keratin obstruct the follicle opening, which forms the precursor to acne. 3. This results in sebum accumulation and swelling of the follicle. 4. Peacans colonize and proliferate in the plugged follicle. 5. This causes the hydrolyzation of sebum triglycerides into free fatty acids. This further plugs the follicle, and pro-inflammatory mediators causes inflammation of the follicle and surrounding dermis. Next. Follicular hyperkeratosis. Hyperkeratosis violates the outflow and leads to the accumulation of secretions in the sebaceous gland. In the sebaceous gland's ducts, microcomedones, tallow horny plugs are formed that do not manifest clinically. Next. Saprophytic skin microflora activity. Bacteria provoke local inflammation of the skin and hair follicles. Propionibacterium acans gram-positive motionless lipophilic bacilli that are facultative anaerobes play the most important role in the development of inflammation in acne. Next. Acne localization. The greatest number of sebaceous glands follicles is located on the face, chest, neck, and upper back. These are the areas of acne localization. Next. Clinical features. Individual lesions are centered on the pilosebaceous unit, i.e. the hair follicle and its associated oil gland. Superficial lesions. Open and closed comedones, blackheads. And whiteheads, papules. Pustules. Deeper lesions, nodules, large painful red lumps, xetocysts, cyst-like fluctuant swellings, secondary lesions. Excoriations, picked or scratched spots, erythematous macules. Pigmented macules. Scars of various type. Next. Comedones. Comedones are non-inflammatory elements resulting from blockage of the mouths of hair follicles. Closed comedones. Open comedones. Submarine comedones respond poorly to medical treatment. Let's guys please watch a short video.
Both whiteheads and blackheads are comedones, which means a hair follicle with a plug made up of oil and dead skin cells that traps bacteria beneath. Microscopic glands in the skin supply an oily substance called sebum to hair follicles, often called pores. Sebum is designed to lubricate the hair and skin and usually drains to the surface. Sometimes, however, the sebum becomes blocked and bacteria begin to grow. If the buildup of sebum and bacteria does not have an opening to the surface of the skin, it is called a whitehead. A blackhead forms if the pore opens to the surface, allowing air to enter. Sebum contains a pigment called melanin, the same substance that gives our skin color. Melanin turns dark or oxidizes if it is exposed to the air, which is why blackheads are dark. They are not dirt, and scrubbing does not remove them. Both blackheads and whiteheads can release their contents and heal, although this process can be slow.
If we look very closely at the skin surface, we can see thousands of tiny openings called pores. These pores are the openings of follicles which are under the skin surface. Tiny glands continuously pump oil, also known as sebum, into the follicles. The oil travels up and onto the skin. The follicle is lined with cells which produce a material called keratin. This keratin joins the oil that is flowing through the follicle. Bacteria can also be found in the follicles. Every hour of every day, this mixture flows out of the pore openings as long as the pores remain open. Unfortunately, pores can become clogged and start the acne process. Creams or makeup may block them, but most importantly, the pores can become clogged by touching or rubbing with the hands. This can push dead skin cells down into the pore or cause a layer of skin to cover the pore. When pores are blocked, the oil and keratin that are being pumped into the follicle can't get out. Pressure builds up and makes the follicle expand like a balloon being filled with water. As the follicle gets larger and larger, this stretches the follicle walls. Tiny holes can form through which bacteria and other contents in the follicle can leak out. This attracts cells of inflammation, which try to fix the problem. The cells lining the canal start to produce more keratin to shield themselves from the increasing stretch. Unfortunately, this additional keratin adds even more material to the canal. As more and more oil and keratin build up, the follicle can actually burst, causing much more inflammation. This is the point where we see red bumps and pimples on the skin.
Next, clinical history of acne. 1. Comedones, Comedosu acne comedonica. 2. Acne papulosa and acne pustulosa, acne papulosa that papulopustulosa. 3. Acne indurata, acne indurativa. 4. Acne phlegminosa. 5. Acne conglobata. 6. Acne fulminans, also known as acute febrile ulcerative acne. 7. Acne inversa or hidradenitis suppurativa. Next, acne can be classified by the type of lesion, comedonal, papulopustular, and nodulocystic. The American Academy of Dermatology classification scheme for acne denotes the following 3 levels. 1. Mild acne characterized by the presence of comedones, non-inflammatory lesions, few papules and pustules, generally 10, but no nodules. 2. Moderate acne presence of several to many papules and pustules 10-40, along with comedones 10-40. The presence of more than 40 papules and pustules along with larger, deeper nodular inflamed lesions up to 5 denotes moderately severe acne. 3. Severe acne presence of numerous or extensive papules and pustules, as well as many nodular lesions. Next, acne indurative. Acne indurativa is characterized by the formation of deep infiltrates with the formation of scars and is prone to merged cystic cavities filled with pus phlegmonous types. Indurative and phlegmonous acnes are called nodulocystic ones. Nodulocystic acne is a sign of fairly severe course of acne. Next, excoriated acne. These are the acnes that occur predominantly in patients prone to excoriate even minor eruptions. Thus, excoriations may be at the background of initially existing acnes and without them. This clinical type may be associated with obsessive neurosis or indicate more severe psychiatric pathology. Therefore, patients with excoriated acne should be advised to consult a psychotherapist or neuropsychiatrist. Next, acne conglobata. Acne conglobata is nodulocystic elements connecting with each other, as well as with large comedones. Lesions can be located everywhere. They are resolved into keloids. They relapse until the age of 40 and sometimes lasts even lifelong. Next, acne fulminans. Acne fulminans, also known as acute febrile ulcerative acne, is a rare severe type of acne. The disease occurs more frequently in men aged 13 to 18 years with mild papulopustular, rarely nodulocystic type of acne, and is characterized by sudden onset, appearance of necrotizing ulcerative elements, mainly on the trunk, and general symptoms of intoxication on the background of chronic severe diseases. Next, acne inversa. Acne inversa is associated with secondary lesions of apocrine sweat glands. Initially, there is occlusion of the hair follicle and apocrine sweat glands are involved in the process again. The disease develops after puberty and is combined with a high body mass. Localization: armpits, perineal region, navel nipple areola. As a result, fistulae are formed with the formation of inverted scars. The course is chronic with relapses. Next, post-acne. Consequences and complications of acne. At a resolution of inflammatory elements, papules, pustules, and nodules, secondary changes, post-acnes are formed on the skin of patients. These are the persistent changes on the skin resulting from a long-term acne and seborrhea and manipulations performed to treat these diseases. Post-acne. Uneven skin texture. Permanent scars. Stagnant spots. Secondary hyperpigmentation, persistent erythema. Dilation of the capillaries. Crushed ice. Hyper and/or hypopigmentation. Psychological problems. Depression, anxiety, social isolation. Intensity of post-acne is associated with age and duration of exacerbations. Next, treatment. Be sure to recommend daily cleansing of the skin. When caring for skin, one should avoid fatty creams and ointments causing hair follicles occlusion. The choice of treatment should be based on anamnesis, adequate clinical assessment of disease, assessment of psychosocial status of the patient with acne. Next, principles of acne treatment. Long-term recurrent disease causes high duration of the basic course of treatment 4 to 6 months, as well as the need for supportive therapy 3 to 5 years. The success of acne treatment is possible only if it affects all factors of pathogenesis. Next, effective acne treatment. Decrease of sebum production. Keratolytic recovery of impaired follicular epithelialization, antibacterial, suppression of Pekin's reproduction, anti-inflammatory effect. Next, safe acne treatment. Good local tolerability. Lack of additional irritant. Possibility of long-term use. Experience of use during pregnancy. Next, mild degree of acne treatment. Mild degree of acne requires only topical treatment. Modern external agents. Benzoyl peroxide, O5-oxytan, synthetic analog of vitamin tretinoin, aerol, retinidapalene defirin. Azelaic acid skin orin. Erythromycin. Combination of erythromycin and zinc, Zener, clindamycin, dalasine C. Traditional drugs, sulfur salicylic acid, resorcinol, zinc, pyrithin. Next, moderate degree of acne. Patients with moderate or severe forms of acne require topical and oral treatment. The above described topical therapy is administered, but usually it is combined with systemic antibiotics at acne of moderate severity. Tetracyclines, doxycycline, minocycline, clindamycin. Next, complications of antibiotic therapy. Dysbacteriosis, Resistance development of normal intestinal microflora and the skin, phototoxic reactions. Drug interactions. It is believed that while taking tetracycline and hormonal contraceptive efficacy of the latter is reduced by 6 to 7 times on colitis, ulcerative esophagitis, benign intracranial hypertension, grayish blue pigmentation of the skin, and the nail plate. Next, severe degree of acne. Therapy. A combination of standard topical and general treatment is necessary to treat severe degree of acne. Long courses up to 3 months or more of antibacterial drugs are administered. In women with severe manifestations of acne with the ineffectiveness of antibiotics therapy, combined oral contraceptives with estrogen profile or anti-androgenic drugs are administered after examination by gynecologist endocrinologist. If after 3 months there is no response to treatment, then isotretinoin is prescribed. Next, severe degree of acne. Therapy to be continued. In most cases, treatment is necessary. Not less than 4 months. 10% of cases -6 months. 3% of cases more than 10 months. Residual effects of acne gradually resolve after discontinuation of the drug therapy. Remission in many cases lasts several years. To reduce the likelihood of recurrence, the total dose should reach at least 120 grams kg. Next, methods of cosmetic correction. Cleaning of face, manual vacuum, ultrasound, cosmetic anti-inflammatory treatment, jacket massage. Cryotherapy. Chemical peelings. Phonophoresis. Phototherapy. Darsenblization. Laser therapy. Next, UV radiation in the treatment of acne. Pros and cons. The question of administration of ultraviolet radiation, UV, to a patient with acne should be solved individually without doubt. Many patients notice improvement in the acne course in summer after insolation. UV causes surface exfoliation, and in small doses, it may stimulate an immune response in the skin. On the other hand, UV enhances comedogenic properties of squalene, a component of sebum. UV in high erythema doses causes a sharp decrease in local immune defense and worsening of acne disease course. Next, let's guys please watch a short video. Acne is a chronic relapsing disease of dermaticosis. Acne is a chronic relapsing disease of facial skin caused by the persistence of Demodex follicularum or Zeliznitsa acne in the sebaceous glands and hair follicles. Next. Photo. Next. Photo. Next. Photo. Next. The cause of this disease is a tick Demodex, the popular name that sounds like Zeliznitsa. There are two separate types. Demodex follicularum, striking the hair follicles of eyebrows and eyelashes, and occasionally scalp and chest may be affected. This type of mite is localized mainly in the hair follicles, forming colonies. Demodex brevis, which prefers the sebaceous glands. Next. Photo. Next. Dermatocyte cover consists of a single row inner epidermal layer or epidermis and an outer cuticle, which in turn consists of a three-layer epi-minus ixoand endocuticle. Next. The mite has a typical spindle-shaped form and short legs. Settling inside the sebaceous glands and hair follicles, it feeds with dead cells and lymph multiplies and forms the colonies. Next. Trigger factors of demodicosis. Pathology of the endocrine system. Gastrointestinal diseases, pancreatitis, dysbacteriosis, gastritis, cholecystitis, etc. Violation of lipid and protein metabolism. Immunodeficiency states. Emotional stress, prolonged stress conditions. Nutritional factors, excessive consumption of coffee, spicy food, alcoholic beverages, bath, and solarium abuse. Next. Clinical forms. Erythematous form is sometimes called rosacea-like due to external displays, and is often confused with rosacea original disease, a peculiar form of vascular neurosis caused by the action of bacterial and fungal microflora. Ticks are not the cause of rosacea, but can significantly aggravate its course. Pustular form is rare. By clinical signs, it can resemble a simple acne, folliculitis, and other forms, but with a predominance of pustular rash. Papular form is the most common one. Size of papules is ranging from 0.5 to 2 millimeters or more in diameter, color from pink to intense red. Combined form of dermaticosis is characterized by the fact that on the skin of the patient all kinds of rashes peculiar to this disease are observed. Next. Symptoms, signs. Pimples, youth acne, rashes, rosacea, pustules on the face are likely to be a manifestation of dermaticosis, red spots on the face. Oily skin, enlarged pores. Affected areas are represented being wet, greasy, have a characteristic luster. Usually the skin on the nose and cheeks is affected. Face has a pale earthy gray tinge. There is increase in the size of the nose, chin, and auricles. Sometimes it is very significant, while the nose begins to resemble a huge blue and red plum rhinophyma. Itching, slight tickling sensation of crawling. Itching worsens by the evening and continues throughout the night. This time is known as the period of the most active life of mites. Usually their mating starts at this period. Itchy eyelids. Loss of eyelashes, and most often, it is a consequence of the activities of demodicosis mites that live in the roots of eyelashes. Base of the eyelashes begin to itch, eyelashes become thinner and start falling. Next, eye damage at demodicosis. Depending on the form of eye damage of patients with demodicosis, there are asymptomatic carriage, obliterated form, blepharoconjunctivitis, and episcleritis. Next, demodicosis treatment. 1. Topical therapy with acaricidal preparations, emulsion of benzyl benzoates, regal aerosol, solution of ivermectin, etc. 2. Correction of comorbidity. 3. Additional methods of treatment and rehabilitation: laser, peels, cryotherapy with liquid nitrogen, and anti-inflammatory treatment. 4. Preventive treatment, autumn and spring. Let's guys please watch a short video.
Scabies is caused by an infestation of the skin by the human itch mite, Sarcoptes scabiei. This microscopic parasite literally eats your skin.
The female mite is attracted to the warmth and odor of human skin. Using its mouth and special cutting surfaces on its front legs, the mite burrows into the host. Once inside, the parasite continues to burrow through the skin, leaving secretions and waste in its wake. It's these secretions and waste products that trigger the body's immune response, causing inflammation and rash.
The scabies life cycle begins when a female mite burrows into human skin. Once inside the skin, the female lays eggs. The eggs hatch and then become adult mites. The adult mites return to the skin surface to look for mates. And when the female successfully mates, the life cycle is complete.
Adult mites will often seek out a new host. They do this by hitching a ride on sheets, linens, or through skin-to-skin contact.
This means that any place where people are in close quarters can be a potential source of infection. Scabies is a fairly common infection. Every year in the US, there are over 1 million cases.
The best way to prevent infection is to avoid skin-to-skin contact with infected persons, and to launder any contaminated linens or clothing in hot water before using them.
Next, rosacea. Rosacea, acne rosacea, gutta rosacea, telangiectasis faciei, tuberose is a chronic, relapsing disease, usually of facial skin, having polychologic nature and characterized by phases of its course. Rosacea manifests itself primarily by arising hyperemia, redness of face, telangiectasia, dilation of small blood vessels on the face, as well as hyperplasia of the sebaceous glands and connective tissue. The basis of the disease: there are changes in the tone of the surface of blood vessels of the skin caused by the action of various external and internal factors. Next, rosacea is a very common disease among dermatological diagnoses. It is about 5% occurs in all races, but mainly in fair-skinned inhabitants of Scandinavia and Ireland. British represent rosacea as Celtic tides. Next, rosacea begins in most cases at the third and fourth decade of life, flourishes between 40 and 50 years. Often affects women. The disease should be called rosacea, from the Latin rosaceus, pink, as used previously. Terms rosacea or acne rosacea are untrue morphology, essence of rosacea. Rosacea is a very common disease in Caucasians, known since ancient times. So, a man with a red face and a bulbous nose was described in the Canterbury Tales, written by D. Chaucer 1340 to 1400. Later rosacea patients appeared in the works of Shakespeare. The famous Italian painter of the early Renaissance, di Ghirlandaio, first depicted a man suffering from rosacea. To be strict, rather a form of rosacea rhinophoma. In the picture, an old man and his grandson, done in 1480 Louvre. Next photo. Rosacea etiology. Endogenous factors. Genetic predisposition, presence of more large and superficial blood vessels on the face. Disruption of digestive tract, gastritis, gastric ulcer, spastic colitis, gallbladder disease. Neurovegetative and endocrine disorders, steroid hormones imbalance, menopause, hypertension. Exogenous factors, climate, eating habits, wrong outer care, emotional peculiarities, intake of certain medications. Next, rosacea pathogenesis. Increased vascular permeability of the skin. Accumulation of mediators of inflammation and metabolic products, serotonin, bradykinin, prostaglandins, opioid peptides, and gastrin. Degeneration of dermis matrix and vascular endothelial damage. Next, classification of rosacea. Rosacea diathesis is occasional hot flashes. Rosacea proper. Stage 1 erythematous telangiectatic. Stage 2 pustulopapular persistent erythema, telangiectasia, papules, pustules. Stage 3 pustulonodular persistent erythema, numerous telangiectasia, papules, pustules, and swollen nodes. 3. Special forms of rosacea: rosacea steroid, granulomatous, gram-negative conlobate, fulminant rosacea with a solid persistent facial edema, ophthalmic rosacea, rhinophoma and phyma of other localizations. Next, rosacea proper is characterized by persistent erythema predominantly of the nose skin, usually with the presence of telangiectasia, with periodic rush of blood to the face as a result of endogenous psychogenic and external stimuli. Demodex mites thus are completely absent or are detected as single samples on the skin, especially in the follicles of the nose. Antiparasitic treatment has no effect in this case. Next photo. Next, Rosacea complicated with dermatosis. In this form, besides the usual phenomena of rosacea, there are scattered micropapules and follicular micropustules in which dermatous seeds are found. At antiparasitic treatment, pustules and papules disappear, but persistent erythema and telangiectasia remain. Next, rosacea-like form of dermatosis in which there is a large number of mites and which may resemble a rosacea proper, but it responds well to antiparasitic treatment. Next, ophthalmic rosacea. Blepharitis, erythema, desquamation and crusts on the edges of the eyelids, conjunctivitis. Iritis, scleritis, keratitis. Frequent symptom of rosacea. Severity of the eye damage does not correspond to the severity of the skin process. In severe cases, it can lead to blindness. Next, hypertrophic rosacea. Rhinophima, Gnadophima, Metophima, Odophima, Blepharophima. It develops as a consequence of tissue hyperplasia of subcutaneous fat and sebaceous glands. The skin thickens, takes on a lumpy appearance, and reminds orange peel. It is observed more frequently in men. Next, rosacea treatment. Elimination of etiological and precipitating factors, treatment of comorbidity. Diet. Antibiotic treatment, imidacloprid antifungal, synthetic retinoids, antihistamines, venetonics and angioprotectors, ascortinum and detralex. Next, topical therapy. Topical anti-inflammatory drugs, cold lotions with 1 to 2% solution of resorcinol boric acid, decoction of herbs, thermal water in the form of aerosol. Topical antibiotics and antiparasitic and parasital means prescribed for rosacea. Papulopustular, metronidazole, erythromycin, and clindamycin. Azelaic acid. Synthetic retinoids. Cryotherapy. For the destruction of telangiectasia laser therapy, argon CO2 laser is used. Photoprotection. Appropriate care, cosmetic bioderma, vene, etc. Calcineurin inhibitors, tacrolimus, pincrolimus.
Today I am here to deal with a problem that has been in my life for probably close to 15 years. Struggled with acne for a long time, and that was what drove me into the skincare industry. Now that I'm aware of all the different options that are available, Dr. Foley has a really wonderful procedure called the Blue Peel that should target all of my main concerns, mostly being acne scarring. It will also help with fine lines and wrinkles and any hyperpigmentation or uneven coloring. Today with the Blue Peel, Dr. Foley will apply a 20% TCA acid mixed with a blue ionic base, which will help to slow down the penetration of the acid as he's putting it on the skin, and he will actually be able to see different endpoints in my skin to be able to tell how deep the acid is penetrating, so he can get down to the level of where the actual scarring is developing at the deeper layers of the skin. And over the course of a week, that entire layer of the top skin should slowly peel off and reveal healthy, much better looking skin. In a few minutes, I will be going back to the OR, and a light anesthesia will be administered to help ease any of the discomfort associated with the peel itself. TCA self-neutralizes usually within 3 to 5 minutes, but during that time, it's a very intense, almost fiery feeling on the face. But once the anesthesia wears off and the peeling acid has done its job, there should be minimal discomfort, just a little bit of tightness. I am very excited. I've seen a lot of good results with the blue peel, and I think it should have a pretty dramatic impact.
Today we're going to do a blue peel on Allie, who is one of our staff. Allie had some problem, like most of us when we were younger, with acne. So she has some facial scarring, and a blue peel is going to be extremely helpful for her, and then it's going to tighten her skin and reduce some of the evidence of the facial scarring. The blue peel was initially designed or invented by a Dr. Obagi in California. We've certainly had lots of different kinds of peels available in the past, but some of the peels that we used to use would cause decreased levels of pigment in the skin, or would lighten the skin too much. And Dr. Obagi, invented this blue peel, and basically it's this blue base with a 30% trichloroacetic acid, and you can see the acid is more or less clear, and then the base is there. Now I'm going to mix that up, and here's our little tube that the base came in. Now we did give Allie some medication before the surgery just to kind of take the edge off. I gave her a few pills to take about an hour ago, and that those pills are just a combination of something to help with nausea, and a little Valium just to help her relax, and then a pain pill, a Percocet. So now, I don't know if you can see that very clearly, but I've pretty well mixed this up nicely. It almost has a blue-green tint to it, and people sometimes look a little smurfy when they first leave here. And these are my applicators here. I just use like a cosmetic applicator. We'll also need some Q-tips, right? Okay, so I'm going to move over to the patient here, and we'll put a little bit on. So what I'm going to do is I'm just going to take my little cosmetic sponge here, and I'm going to start putting this on Allie here, and I want to do it really evenly. And she's going to feel a little warm here from this. I'm going to do certain areas more than others because certain areas have more scarring, and I want to get more of a deeper peel in areas like the cheeks and the forehead. And I don't really care so much about her nose or her eyelids, but I am going to peel everything with at least one coat so it looks uniform, and I'm going to try to blend it onto her neck a little bit too. And you can see by the color, I can tell that we're getting it real uniform. All right, now I'm going to kind of blend it onto her neck a little bit here. Not much, but just kind of, just a little bit here. And the color that we see gives us an idea of how deep we are here. There you go. What's going to happen is her skin is just going to get so tight that she is going to be probably afraid to laugh or smile because it feels like your skin is going to break. It just feels that tight. Kind of like if you've seen a riverbed that gets all dried up and it kind of gets that tight and then starts to crack, and then it'll peel. Usually about 3 or 4 days out, everything just peels off. So this outer layer will just peel. What we do once we're all done, as soon as we stop putting this stuff on, she won't have any more burning. And what we'll do is have the nurses go ahead and use a cleanser. And they won't be able to get all the blue off. She'll still look pretty smurfy when she goes home. But at least they'll be able to get some of this blue off her skin. That's the nice thing about this blue. I can really tell if I need to do a little bit more here and there. And you can see how I kind of blended it down here on her neck, so it's not a real sharp line of demarcation. And people that have the sun damage on their skin with a bunch of brown freckly spots, boy, it works great to get rid of all that stuff. Pigmentation, like from pregnancy, people have that mask of pregnancy, can really tone that down. And if somebody just wants to lighten their skin, that'll do it. I think with this 2-coat that we're giving her, she's probably going to get, maybe half the effect that she'd get from a laser. But with a CO2 laser, we have to do an anesthetic too, so it's more expensive and it's a lot bigger of a deal as far as the healing after surgery, and where this is just the skin gets super tight and then peels off. You don't have to wear a special mask or anything like you would with the CO2 laser. This is perfect for somebody who has, just doesn't need a facelift, but needs some tightening on their skin and wants to look younger. It's just a great procedure. Somebody like who's 40 or something like that comes in and say maybe they want a facelift, but they don't really have a lot of extra skin. They just need a little help. When you take the outer layer of the skin off, you're going to have some sensitivity to the sun, so it's not necessarily the best thing to do right at the beginning of the summer. It's something that you'd want to do preferably in the fall or the winter, where you don't have to worry about using sunscreen. You can certainly have it done in the summer, just you have to be a little more careful. But this is a very uniform result. Looks really good. She should do very well.
So this is day 6 from the blue peel. It was done last Thursday. It's now Tuesday morning, and as you can tell, I still have a considerable amount of peeling. I've put a lot of sunscreen on my skin to protect from even the UV rays that are coming in through the windows. I haven't been outside at all, but it's still very important to protect the skin. Other than that, there's no discomfort at all. All of the peeling has subsided around my mouth, which was causing a lot of tightness initially, making it hard to eat and talk comfortably, but that's all gone away and I'm feeling pretty good. Results are promising, so I'm very excited. It's been about 5 weeks now since the initial blue peel. Been very happy with the results. I think the first 3 weeks were the most difficult, just with redness and sensitivity and adjusting to the whole process. After having gone through the blue peel myself, I would definitely recommend taking your sun exposure seriously. Anybody who's considering a blue peel, it is going to be very important that you apply your sunblock possibly several times throughout the day if you're going to be outside, and even wear a wide-brimmed hat to avoid any possible sun exposure. But once you get through the first probably 3 or 4 weeks, you should be good. The main reason I was doing this blue peel was to treat some of the acne scarring that I developed earlier in life, and I think the blue peel did a very good job at leveling a lot of that out. But I've been receiving a lot of compliments on my skin now and been able to notice a change with texture and just the tightening of the skin around the eyes and overall smoothness. So it's been very, very enjoyable.
Thanks for your attention.